Hello everyone, I am Dr. Sarita Jain. In today's video, I am going to discuss about the recommendation for the use of aspirin during the pregnancy and what are the conditions where we should not use it and what are the complications in mother and fetus and what are the contraindication for the use of aspirin during the pregnancy. So according to ACOG and the Society for Maternal Fetal Medicine, aspirin is indicated in patients who are high risk for the preeclampsia. In patients who are at high risk for the preeclampsia, low dose aspirin is started at the 80 milligram per day dose and it is started between 12 and 28 week of the gestation, but it's better if started before the 16 weeks and it is continued daily until after the delivery. If there are moderate risk factor for the preeclampsia, then it can be considered for when more than one moderate risk factor for preeclampsia are present. High risk factor for preeclampsia are if there is history of preeclampsia, especially when accompanied by an adverse outcome, multifetal gestation, chronic hypertension, type 1 or 2 diabetes, renal disease, autoimmune disease like systemic lupus erythematosus and antiphospholipid antibody syndrome. Aspirin is recommended if patient has one or more of these high risk factors. Moderate risk factor for preeclampsia are nulliparity, obesity when body mass index is greater than 30, family history of preeclampsia, socio-demographic characteristics like African American race, low socioeconomic status, age 35 years or older, personal history factors like low birth weight or small for gestational age, previous adverse pregnancy outcome, more than 10 years pregnancy interval. So, low dose aspirin is recommended if the patient has more than one of these moderate risk factors. Low risk factors are previous uncomplicated full term delivery. In this condition, low dose aspirin is not recommended. Aspirin is a cyclooxygenase inhibitor. It is known for its anti-inflammatory and antiplatelet properties. During pregnancy, low dose aspirin has been primarily used to prevent or delay the onset of preeclampsia. Also, it has been suggested for the other uses such as preventing stillbirth, fetal growth restriction, preterm birth and early pregnancy loss. Aspirin inhibits the cyclooxygenase, that is COX enzyme, which affects the prostaglandin production. COX-1 produces thromboxane A2, which promotes blood clotting and vasoconstriction, while COX-2 produces prostacyclin, which inhibits blood clotting and promotes vasodilation. So, at low doses, that is 60 to 150 milligram per day, aspirin selectively inhibits COX-1, so it reduces the thromboxane A2 level while allowing COX-2 to produce the prostacyclin. This helps balance the effect of thromboxane and prostacyclin, potentially improving the blood flow. In preeclampsia, there is high blood pressure and poor placental blood flow. It is thought to result from the poor placentation, which may include issues like ischemia or abnormal immune responses. Aspirin use reduces the thromboxane effect by inhibiting COX-1, improving blood flow to the placenta. Now, what are the maternal risks along with the use of aspirin? Most systemic reviews and randomized controlled trial have found no increased risk of the major hemorrhagic complication with low dose aspirin. Specific risks such as placental abruption and postpartum hemorrhage were not significantly increased in studies. In pregnancy related studies, transfusion risk was slightly higher in those receiving low dose aspirin. Now, fetal risk associated with the use of aspirin. Systemic reviews and RCTs have not found an increased risk of the congenital anomalies or adverse fetal effect with the low dose aspirin use. Some studies have suggested a possible association between aspirin use and an increased risk of the gastroschisis. Low dose aspirin in the third trimester have not been associated with the premature closure of the ductus arteriosus. Older animal studies raise this concern, but recent large-scale studies have not found an increased risk in perinatal death due to the persistent pulmonary hypertension. Recent Cochrane meta-analysis and USPSTF systemic reviews have found no increased risk of neonatal intracranial hemorrhage or other hemorrhagic complication associated with the low dose aspirin use in third trimester. Now, what are the contraindication to aspirin use during pregnancy? Absolute contraindications are allergy to aspirin or salicylates, NSAID allergy, nasal polyps or asthma with aspirin-induced bronchospasm. Relative contraindications are gastrointestinal bleeding or peptic ulcers, other bleeding issues, severe liver problems. It is also contraindicated in Reye syndrome in children under 18 years, and be careful if there are obstetric bleeding risk. Now, when to start aspirin during pregnancy? Usually it is started between 12 and 28 week of the gestation. Best results are obtained if it is started before the 16 weeks. If it is started before the 16th week, it reduces the risk of severe preeclampsia and poor fetal growth. But if it is started after the 16th week, there is slightly lower risk of the preeclampsia, but it is less effective for other issues. Now, when to stop aspirin during pregnancy? Some protocols suggest stopping at 36 weeks, but there is no clear evidence that this avoids the excessive bleeding. In practice, many discontinue aspirin around the 32 weeks to reduce the risk of bleeding, especially in patients where preterm labor is expected. Low dose aspirin does not usually interfere with the spinal or epidural anesthesia. Now, what are the indications for the use of low dose aspirin during pregnancy? It is recommended for the prevention of preeclampsia. The hypothesis that preeclampsia might be linked to vascular disturbances and coagulation defects led to the initial studies of aspirin for preeclampsia prevention. Small trials suggested that the low dose aspirin could benefit high risk women, but larger RCTs, including a multicenter trial, showed a significant decrease in preeclampsia risk with 150 mg aspirin. Now, what are the recommendations by USPSTF? According to this, low dose aspirin started before 12 weeks of the gestation modestly reduces the risk of preeclampsia in high risk women without adverse fetal effect or increased maternal bleeding. Now, what are the guidelines from ACOG and SMFM? ACOG and SMFM also support the USPSTF criteria, and they recommend low dose aspirin for high risk women. Aspirin should be started between 12 and 28 weeks of the gestation, optimally before the 16 weeks, and continued until delivery. Women already on low dose aspirin for other medical reasons before 12 and 20 weeks can continue their treatment. Now, what are the conditions where low dose aspirin is not beneficial in the absence of preeclampsia risk factor? Number one is stillbirth. Low dose aspirin is not recommended for women with the history of stillbirth without other preeclampsia risk factor. Next is fetal growth restriction. Low dose aspirin is not recommended for preventing recurrent fetal growth restriction in women without other preeclampsia risk factor. Next is preterm birth. Low dose aspirin is not recommended for preventing spontaneous preterm birth in the absence of preeclampsia risk factors. While there is some evidence of reduced preterm birth in women at risk of preeclampsia, the benefit for spontaneous preterm birth alone is not well established. Next is early pregnancy loss. Low dose aspirin has not been shown to prevent unexplained early pregnancy loss in women without antiphospholipid antibody syndrome. So, this was all about use of aspirin during the pregnancy. If you found this information useful, please like and share the video and subscribe my channel. Thank you.